Brian, can you discuss for a minute some of the different theories and how your theory fits in with some of the others?
Yes.
There are muscular theories, disc theories, facet theories. How does mobilizations with movement and your concept of these techniques fit in with some of those theories?
No problem. I was puzzled for many, well, not for many years, but for some years, about the difference between facets and discs and the importance of each structure in the spine. Now, Mackenzie deals with the disc. Mackenzie came up with his theories of distortion of the disc, reproduction of central pain or distal pain with movement, and he's got heaps of scientific proof which justify what he does. Now, we're talking here about the disc. And if Mackenzie's got all this proof, how is it that people throughout the decades who manipulate, now the chiropractors, osteopaths, I've had a manipulative background, how is it that these people can succeed or get results when generally it's the disc that's involved? And I have a way of marrying or putting the two together. I'm going to try and explain to the viewer what I think is going on. There's a vertebrae, there's the other one, the disc is the space in between. Now, we know this is just straight out what happens normally with a normal disc. When you bend forwards, the disc approximates ventrally and separates dorsally. And therefore, the discal contents formation, if you like, changes. Instead of being a slab of equal thickness, now it's like a wedge. Now, that's normal. When you talk about disc pathologies, when the patient bends forwards, the disc is being squeezed dorsally because there's a weakness in the posterior wall of the disc, and it's touching structures like nerves, and you can get sciatica or whatever. Now, coming back to the normal joint, for a normal joint to function naturally, you've got facet joints dorsally that must be free and mobile, because as you bend forwards, those facet joints move. Now, if the facet joints are jammed for any reason whatsoever, from some fall or lifting, the disc cannot distort naturally. In other words, when you bend forwards, the vertebral bodies come together in front, but at the back they're not separating because the facets won't let them. So where does the discal content go? It tends to extrude dorsally and cause troubles. And quite often you'll get a patient who, when they bend forward, they feel pain, and the assumption is it's discal, but you get onto a facet joint and make it separate. You unjam it, and when they go forwards, that pain that they have has disappeared.
So when you say unjam, if they can't bend forward, one would assume that the facet doesn't open.
That's right.
But if you're referring to unjamming, it might be that the facet is in a closed pack, but it's stuck closed, and your repositionings, your snags, bring it back to a more biomechanically correct position.
Okay. Can I go to spine for a minute?
Sure.
It's good to have a spine.
Absolutely.
Yeah. Can we just make a few observations while we've got the spine here? First of all, you can see the facets each side, you can see the orientation, you can see that the treatment planes are almost vertical. And when you flex, that facet moves up, and when you extend, it comes down. And I presume that these facets get sticky or stuck, and when you bend forwards, it can't do that. Now, if you look at the vertebral bodies, when you flex, you can see they're coming apart dorsally. The viewer can. That's what this is for. You know this. You can see it comes apart as it comes together in front. If that facet's not moving, it cannot come apart. That can only distort naturally if you've got a mobile facet. So therefore, when we're talking about snags, we are locating on spinous processes and transverse processes and making them move. We're unjamming them. We're actually making them function. And while we've got the spine, can we just show that the ilium project backwards on the sacrum, and you cannot, with your hand, for instance, make contact with L5.
Right, and that'll be useful. That'll be a useful visualization to have when we start talking about snags at the L5 segment.
Because there's the facet joint there. All you can do if you want to move a jammed facet at L5, S1, you can locate on each side on the articular pillar, and you can in fact move it readily with your thumbs. It's a matter of knowing where to put your thumbs, having the knowledge and the skill. Once you get above that, and you cannot make contact with the transverse process. It's out of reach because of all the structures on top of it. But then as you come up, you can. And another observation, there's the spinous process of L4. There's the transverse. It's higher. And as you come up, you'll find that they're not level, but the transverse process is more cranial. And there, of course, it's almost an inch above, well, it's over an inch above the tip of that.
And when you're saying you can't make this contact on the spinous process or the transverse process, you're referring to your thenar your hypothenar contact,
yep,
right?
That's right.
But you can make that contact with your thumbs.
Yes, of course you can. Yep. But we'll go through that in more detail as we get a victim and show what to do.
Great. Brian, when you're treating a patient, there's different theories out there, as you have discussed: disc theory, facet theory, muscular theories. But when you're treating a patient, you're not just thinking of one theory or another. You're thinking of a vertebral segment, and that segment is comprised of the disc and the facets. And therefore, when you're treating the patient and they respond either positively or negatively to your treatment, you're making an assessment of whether that response is due to disc changes or facet changes, correct? Or both, correct?
Yes, now when I'm teaching, I will do what Mackenzie would suggest if it's applicable. I'll give patients extensions in standing or heart press-ups, because that is excellent for the disc. It's doing what he describes in his book, and that's not our brief here today. But I also treat the facets. I treat the segment. So I'm looking at a way of influencing the disc and influencing the facet. So I think that's a more complete approach. For instance, just do extensions and standing. There's an awful lot of compression going on in the facets.
Right.
And after I've given them some extensions, I might do something just to release those facets because of what happens to them when you hyperextend.
At least here in the United States, chiropractors are the primary joint manipulators. Physical therapists provide many levels of graded mobilizations.
Yes.
Mobilizations with movement, in my opinion, it fills the gap between manipulative therapy because it's so forceful and strong. It provides a grade 3 mobilization with end range overpressure, and that fills between some people who do passive, grade 1, grade 2, grade 3s, and that's all they do. There's so much benefit to deforming the joint capsule and opening and spreading joint surfaces. I'm trying to describe how it fills the gap between. Is it a point that needs to be mentioned? Maybe we don't have to say it.
I think we do fill a gap. I think we, you see, I asked a chiropractor, I was having breakfast with him some years ago, and I said, look, I'm a manipulator, you're a manipulator. I said, what do you think you achieve when you manipulate? He said, I'm trying to restore function. That could not have been a better answer. I'm trying to restore function with what I do. And I think anyone treating a bad back's trying to restore function.
Well, chiropractic is based on joint manipulation.
That's right.
The premise is manipulating the spine, and there has to be a tremendous effect to the facet joints, not just the disc when that happens. Right. And there's got to be, you see how many people get up off the chiropractic table after having spinal manipulation and feel absolutely relieved of their symptoms. So there has to be plenty of truth or basis to the concept that
that wouldn't have survived.
Right.
Oh, good heavens, it would have gone downhill. And it's there. It's got a place. Manipulation has a place. There's no question about this. And Mackenzie, he's got more proof than anyone for what he does for the lower lumbar spine. As we go up the spine, I think things change.
Right.
I think outcomes change, and the way we treat other sections of the spine, we've got a great deal to offer.
Absolutely.
And I do like the fact that we're telling you something that works today. The patient comes in, they've got pain when they go back. They walk out, they've got no pain when they go back, and they've got something to do at home, and we'll show you this. They can go home and maintain that improvement. They've got self-treatments that are going to appear on these clips that they're watching.
Well, let's show a few of these techniques.
Yes.
All right.